Okay, good morning and welcome to March. Everyone here this morning is awake and rowdy. That's good, bodes well. Hi, welcome to March Grand Rounds as well as March. I saw some flowers blooming on the way in this morning, so that's welcome. Hi, we have a great presentation this morning, but before we get going, we just want to go over our land acknowledgement as well as celebrate Developmental Disabilities Awareness Month. And just a reminder for everyone that's joining us online this morning, please make sure you're muted until our question and answer session. So if you have a microphone that's unmuted or if you've called in, just make sure everything's on mute. We want to start this morning by acknowledging that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with deep gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of the free enslaved labor of Black people, and we honor the legacy of the African diaspora and Black life, knowledge and skills that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of the privilege and oppression and how they play a role in the lives of patients, families, and employees, and we strive to be anti-racist and improve care for those with less privilege. And we want to start this morning by celebrating Developmental Disabilities Awareness Month. There is a QR code on the screen that will take you to some information about how to spread awareness and celebrate this month. And then I also just wanted to call out some of the centers here that serve the developmental disability population and families. We have the Alyssa Burnett Adult Life Center here, as well as IHDD. And then, of course, Seattle Children's Magnuson and the Autism Center. So without further ado, I will introduce Elizabeth McCauley to talk about our speakers this month. Oh, I'm so sorry. With a little bit further ado. Just a reminder that the faculty meeting after this will be virtual only this month. Sorry, Elizabeth.
Okay. Thank you, Michelle, and thanks to all of you
Molly,
that are here
and
in
I
person
apologize for
and
interrupting,
online.
but we're not able to hear right auditorium audio.
Thanks for letting us know that, although you can't hear me.
I can hear you now, Elizabeth. How wonderful.
You can hear me now? Okay, I'm going to keep going.
Yes, we can. Thank you.
Thanks a lot. So it is... Okay, I'm repeating one of the announcements. The faculty meeting, even though there's some of us who have gathered, the faculty meeting is only going to be remote, so it will be an online meeting, and we welcome everybody to join in. So I'm now switching to introduce the speakers for today, and it is with great actually honor and pleasure and joy that I get to introduce this team, and that I also get to acknowledge with them that this year we are celebrating the 10th anniversary of the beginning of the Smart Center. Although I think we'll hear a little bit about all the roots of the Smart Center that started even well before that. So congratulations. I'm going to introduce Erin Lyon, who I think most of you know, professor in our department and the director of the Smart Center. Eric Bruns, I'm pointing to these folks as if you could all see them. Eric Bruns, who, again, a professor in psychiatry and behavioral sciences and the associate director for the Smart Center. And Jen Stuber, who is a faculty member in social work, has started, as most of us know, as I think everybody knows, Forefront Suicide Prevention, but has more recently become a partner in the Smart Center and is working on those kind of interventions to affect suicidal risk in the schools. I also want to call out Kelsey Schmidt, who could not join us this morning, but who has been a pivotal player in this work and really needs to be acknowledged for her leadership in the work in the Smart Center. So today's presentation will center on work done over the last decade that's been led by the training and technical assistance team within the Smart Center. And it's really going to be focused on the efforts that they have made to take evidence-informed, tested intervention models, both systems models and specific clinical models, into the schools and work with school districts and individual schools to try to implement these models and integrate them to improve mental health services in the schools. So before I pass on the hat to move on to the presentation, which is school mental health, what works to get, what works and what works to get the work done, which is really a huge issue. I want to point out that both of our directors of the Smart Center have matching Smart Center socks on this morning. And so I wish you were here to see them, and there we go. If you can see them now, they're holding up their socks. So this is a very warm and hardworking and hugely productive group of people who have contributed greatly to the Department of Psychiatry and the work of the division. I'm going to pass it over, I think, to you, Erin.
I think Elizabeth might have socks somewhere. Thank you so much, Elizabeth. Let's see, where are we advancing it with? Are we just doing that? Okay. First of all, the socks, just for those at home. Our Smart Center socks, we're very excited about our Smart Center swag. So I'm Aaron Lyon, professor in the department and the director of the Smart Center. At this sort of 10th anniversary point, I also want to acknowledge past directors. Doug Cheney, who was my original co-director from the College of Education when we first started things off, and more recently Jill Locke, also in the Department of Psychiatry. But I come to you as the sole current Smart Center director and one of the original Smart Center directors. And we really think about the Smart Center as a research and technical assistance center focused on improving, broadly defined, the social, emotional, and behavioral services and well-being of school buildings, educators, students, and families. So we do that through a lot of different things, many of which you can see on our website. So if you want to get some up-to-date information, both about what we're doing and also about how we tend to organize ourselves, that's a good place to go. We have an array of core and affiliate faculty at the Smart Center. I won't run through everyone's name, but they are fantastic colleagues and contributors to this work. One of the things that I love most about the Smart Center is the values alignment in terms of how and really why we do our work, and the importance of the school setting for creating accessible opportunities for high-quality mental health service delivery. Again, broadly defined across what we would say in schools, all tiers of service delivery, which is really an educational application of the public health model focused on universal prevention, selected and indicated interventions at higher levels. We also have a whole bunch of fantastic staff, who I also won't go through naming. But if you multiply the column by the row, we have 28 active, wonderful staff at the Smart Center working across both our research and our technical assistance domains. This gives you just a little bit of a sense of how we kind of organize the Smart Center and our work and the entities that come together in order to create what we call the Smart Center. We began in the Department of Psychiatry in the School of Medicine and the College of Education. But as Elizabeth was just noting, we're very excited to have sort of further incorporated the School of Social Work and to have that representation here as well. That was the school, having School of Social Work involvement was actually always in the back of my mind, or even sometimes clearly stated as a goal of the Smart Center. So it's pretty fantastic to actually be there at this point, given the alignment of our work with that of so many of our colleagues in social work. We engage in a lot of different kinds of work. outreach and partnerships, have a large component of our work dedicated to mostly federally sponsored research. We engage in workforce development. We'll talk some about that later today. Training and technical assistance, and policy-oriented work to advocate for the students and families in the state of Washington and beyond. So our mission, briefly stated, is to promote high-quality, culturally responsive programs, practices, and policies to meet the full range of social, emotional, and behavioral needs of students in both general and special education contexts. And as I was saying, we have a large research core that's made up of a few different pods where we are doing primarily work funded by the National Institute of Mental Health and the Institute of Education Sciences, which is the Department of Education's major research funding arm. We have our ever-growing and quite large, as it stands, training and technical assistance core, which is primarily what we're here to talk about today. We had a grand rounds in December at the broader psychiatry department level, where we talked primarily about the research that we conduct. So this is in a lot of ways with a 1-2 punch of research and technical assistance spread across 2 grand rounds. And also increasingly a focus on policy, both sort of tracking state policies and trying to communicate about that with our communities, as well as, when indicated and when asked, contributing and working with legislators in order to make sure, again, that students and families and educators are getting what they need in order to be most successful in their jobs. A quick incomplete history of SMART milestones. It was very fitting to have Elizabeth up here because the history of the SMART Center and the history, I think, of any successful organization is a long one and sometimes predates any official beginnings. And I think that's totally true for the SMART Center, which dates back to a partnership with the Public Health of Seattle and King County that Elizabeth led, in addition to a colleague of ours, TJ Cosgrove, that really started to solidify early partnerships with public health and Seattle Public Schools that provided a foundation for what we've kind of built out to today. And that happened well before I ever arrived in Seattle. In 2012, we received our first grant that was PI'd by Elizabeth and Eric, and that a lot of us worked very hard on to develop what we called BRISC, our Brief Intervention for School Clinicians. And in a lot of ways, I mean, really in all the ways, was the first opportunity for us to formally come together between those of us who were in the psychiatry department and our colleagues in the College of Education. And we realized, hey, we like this. We have, there's a lot of great work that we can do, and the rest is history. But the formal history started in December of 2013, which is when we got our official letter from the provost saying, yes, you can call yourselves the SMART Center. And with that, we move forward into a variety of different grants. Our first official federal grants were awarded in 2015. Our first NIMH grant was 2016. Our first large SMART technical assistance projects, and this is really where you begin to see the emergence of what has transformed and become and grown into our technical assistance and consultation core, began in 2016 with some close partnerships with Marysville and Skagit County. We, as part of our training mission, not just for professional development for those already working out in the community or even those preparing for service roles, we also try to engage in professional development for people, for researchers, and Eric led a IES-funded postdoctoral training grant that allowed us to have some fantastic colleagues come through and support their both research and supporting them to do some technical assistance work as well. In 2018, we received a school supplement for the Northwest Mental Health Technology Transfer Center that's housed here at UW. That was led by Eric. And this provided SAMHSA funding to further supercharge some of our technical assistance work throughout Region 10 of the US. In 2020, we got our 10th IES grant, just sort of seeing that research productivity continue as the technical assistance work that we do has continued to develop. In 2021, we received IES funding to launch what we call the Research Institute for Implementation Science and Education, or RISE. And RISE is a training grant for faculty, researchers who are working in the educational space all over the nation and who come and learn about doing implementation science and how to do that, whether they're social, emotional, and behavioral focused in their work, or if they're trying to figure out how to implement an effective mathematics curriculum. In 2022, we got our 10th NIMH grant, and then particularly relevant and moving forward into what we're going to be talking about today, but not solely on this, in 2023, led by Jen, led by Eric as well, the Smart Center launched the Workforce for Student Wellbeing initiative, which is a fantastic opportunity and resource to make sure that we can improve the number of school-based, of school social workers available to provide evidence-based supports to students and families. So some quick things by the numbers, although I think these are already out of date from December and probably higher. We have active projects in 720 school districts, which equates to approximately 3,600 school buildings. And I think now it's over $50 million in active grants and contracts. So there's been this tremendous growth, starting with research, evolving into a firm sort of collaboration and dual focus and set of projects that focus on both research and technical assistance and consultation. And it's the latter that we'll be moving into today, and I'll hand it off to Eric Bruns.
Wow, that was a whirlwind. Yeah, so I'm sorry, I've got a little bit of a cold. Hopefully my voice will hold up. But the last time I did a grand rounds here was in 2005, 19 years ago to the day. Ann Vanderstoep and Elizabeth had a cancellation. And so they said, let's get the new guy to come up and do something. Yeah. So how new was I? It was my first official day on the job. It was the last time that I presented. I presented on community-based intensive care coordination for kids with the most serious emotional behavioral needs. And so it'll be an interesting question what I'll present on in 2043, because that will be the next milestone, I guess, right? So all the work that I've been doing more recently, however, has been in the Smart Center and working further upstream in school mental health. So I kind of like to say my career was focused on the kids who cost systems the most heartache and money, which are the kids with the most serious and complex needs, served by multiple sectors, wind up in residential and inpatient facilities. How do we keep them in home, school, and community? And then the setting where kids are most likely to get care. So it's kind of like the kids who are most costly, and then where we're going to get to the most kids, which is schools. So, I came here from Baltimore and the University of Maryland. Back then I wore a lot of turtlenecks, didn't have any gray hair, but I was a school-based clinician at Cherry Hill Elementary in Southeast Baltimore, working with Mark Wiest and Sharon Hoover at the National Center for School Mental Health. But my not yet quite spouse convinced me to come out to Seattle, and UW was gracious enough to have me. So as Aaron was saying, we established this partnership with King County Public Health because, because of the work of folks like Elizabeth, we published a couple of papers asking about the impact of the mental health component of our Seattle school-based health centers. And this was based on work that I'd already been doing with administrative data in Baltimore. But what we found was that students who use the mental health component of our school-based health centers in Seattle, which have grown since, we like to think that the data has helped encourage its growth and the funding of these centers. The kids who received the mental health component of the school-based health centers work were more likely to experience improved attendance, grades, and achievement than those matched by propensity score who did not receive the services. Similar kids. And so from there, we really started to dig in on this, asking what works in school mental health, and, like the title today, what works to get it done. So to do so, we're going to be drawing from an example of the Training and TA Center, as Aaron was just talking about. And you see our fearless leader, Kelsey Schmitz, up there in the corner, who would be presenting today, but she's getting her doctorate. and class days are the first Friday of every month, exactly the same time as Grand Rounds. So unfortunately, you get me and my croaky voice today. But like Erin was saying, we hired her in 2018 to run the Northwest, SAMHSA-funded Northwest Technology Transfer Center for school mental health. So Smart TAC, as we like to call it, has interacted with hundreds of school and community providers who touch the lives of thousands of children. And we do have this focus on the 4-state SAMHSA Region 10, Alaska, Idaho, Oregon, and Washington. But we have had thousands of participants because of the virtual world, as evidenced today with our nice 15 people in the room and 177 on screen. We can really increase our reach. And we actually did a research paper that showed that we had no less impact, according to the participants, when we went to virtual during COVID than with the same methods that we were evaluating the impact of our work before we went fully virtual. So just in the last year, so our goals are indeed to provide direct training and TA on the implementation of mental health services in schools, and build that infrastructure and create learning communities, support educational leaders to promote the mental health for all. We have gone as far as the northern tip of Alaska, to Nome, Alaska, to do this work, and all the way down to the southeast corner of our country, to Florida. So today, what we're going to do is just look at how the SMART TA Core is an exemplar for how we get what works in school mental health done in the real world. And we'll describe the characteristics of fully functioning school and community interconnected mental health systems of care. And a big emphasis of this is the point that the work requires building systems, okay? Not just implementing programs. Researchers like us love programs. Clearly we do, because there are thousands of them. It's a lot easier to randomly assign people to get a program or not, or a school to do a program or not, than to randomize districts or states to having different kind of system structures or system building. But when it comes time to actually get the work done, implementation science and our hard lessons on the ground say the things that are important are the organizational and system factors, leadership, climate, teamwork, the MOUs between the schools and the community providers, the funding and policies that undergird what kind of trainings and professional development that teachers have to have or don't have to have, as is more often the case in terms of behavioral health. So this is why we take a systems approach. The reason we do school mental health is really obvious. I'm not going to dwell on the problems that you all know all too well. That diagnoses of depression in youth have doubled from 2011 to 2021 and have only increased since the pandemic. In Washington, our Healthy Youth Survey from 2021 showed that by high school, almost 3/4 of young people report experiencing anxiety. Almost half report experiencing symptoms of depression. Nearly 1 in 5 say that they've had suicidal thoughts. And when they're asked, if you are struggling with your mental health, do you have an adult to turn to? Almost a fifth of our 12th graders say that they wouldn't have anybody, right? So we also know that the vast majority of youth who need help won't get it due to a host of factors. There's a lack of clinicians, and the turnover and attrition from the field is just growing. Long wait lists, inadequate insurance, but also social stigma and medical racism, distrust of clinical settings, and low availability of effective treatments. So, when adults need to act, whether it is a calamity such as a hurricane or a wildfire, or the ongoing crisis in youth mental health, who do adults turn to? Where do adults turn to get youth the help that they need? One of the most powerful kind of examples of this was done by our colleague Lisa Jaycox, who, after Hurricane Katrina hit, documented that was able to kind of do a natural experiment where some of the youth, some of the children and adolescents, of the 60% who were exhibiting symptoms of PTSD, were referred to clinic-based care for those problems, and some were referred to school-based care. So anybody have a guess as to how much more likely it was to get the help that they need if they were referred to school versus community-based care? A lot, right? It's about 3 times more likely. So almost all the kids who were referred to care in schools got the treatment, but less than 40% who were referred to community-based care got treatment. So this should not surprise us because schools reduce barriers to care. Transportation, often costs are reduced because, like in Seattle, any kid can go to the school-based health center and ask to see a mental health clinician, where those kind of resources are available. But it reduces stigma and other barriers as well. And Aaron and others have found that schools reduce the gap in access for youth of color because it is more accessible and there are fewer barriers to care for those minoritized youth. So for many years we were told, well, schools are clearly a major venue for where kids are going to get mental health care. But a lot of that was just based on a single study from the 1990s done in the Smoky Mountains of North Carolina. So very recently, the SMART Center, as part of that research component that's intended to inform policy and practice, said, let's do a meta-analysis of all the studies that we can find that ask where do youth receive care. So we found 23 such studies that assess the rate of youth mental health service receipt by sector. And some of these were general population samples, and some were just samples of kids with symptoms or established diagnoses. So what sector do you think the meta-analysis of 23 studies found that the general population of kids, where are they most likely to get mental health care? Any thoughts? Schools. But it's a trick question because it was a virtual tie with outpatient clinics, okay? Like 0.02, something that is non-significant to be sure. So, and this held up even if you looked at kids who were experiencing mental health symptoms or who had a diagnosis. The proportions of those youth receiving mental health services, again, was most likely in schools, which you might not expect. But it's the case in our systems of care. But again, closely followed by community-based providers. So the message we take away from this is that if we're going to build an effective response, we really need this partnership between schools and community partners. Bring them together to say, schools are the place where we have adults with eyes on kids, where we can have a trusted adult who is asking how kids are doing. We can do social emotional learning. We can do early intervention. But as you can see, you flip that triangle and say, when it comes time for an intensive intervention, we have to be clear where our referral pathways are, what our procedures are going to be to access effective care in the community. So how do we do this? How do we respond to the need with this interconnected, multi-tiered school mental health? So one way to think about this is let's look at the cascade of events that children might experience as they move from dysregulation to more intensive need. And with thanks to our colleague Elizabeth Koshman at Trails to Wellness, who kind of came up with the basics of this kind of sequence and this kind of conceptual model. So we know that children and adolescents are experiencing greater stress and emotional dysregulation than they used to. We've seen the data, right? Those 75% of kids in 12th grade, 65% of kids in 8th grade, which my kid will be in next year, say that they experience depression or anxiety. Those aren't necessarily clinical symptoms, but those rates of those feelings and that stress and that dysregulation has been on the rise for many, many years, okay? First among the list of stressors, we put this here for a reason, academic stress. It's not bullying, it's not social media. It's grades, homework, and school achievement. Am I going to get enough credits to graduate? We know this because the SMART Center asked it of the data from one of our clinical trials on BRISC. 451 kids, 3 states, 15 districts, 54 schools, very diverse. The number one problem that they came to a school mental health clinician for, by far, was school stress, homework and grades, okay? So right off the bat, here's data that we're trying to now, kind of mobilize. What better way would there be to intervene in that first part of the cycle than to have folks who are charged with helping kids with their academics be able to problem solve with them right off the bat when that's been revealed, okay? But of course there's other issues that are rising in our society, political and climate stress, and indeed social media-driven loneliness, body dysmorphia, and so forth. So this can obviously lead to higher rates of anxiety and depression as well, especially when we have such a limited workforce right now. A thing that can happen to a lot of kids is feelings, desperate feelings, and youth suicidality. It is now the second leading cause of death among teens. In some states, it's the number one cause. And as Jen will describe, adults, teachers, parents, and peers are not equipped to even have those conversations. Again, what better place to find a way to have community and support for all kids who might be experiencing that than schools? And then finally, we have to ask, how do we do that connection to our providers, our clinics, our hospitals, and figure out when kids and parents get to this point, how do they navigate a system that can feel incredibly daunting? All of these things are our responsibility if we're going to have an adequate response. And again, when you see schools and community outpatient providers being so prominent, we have to get them to work together. Oh yeah, so here was the data. Oops, I thought I hid this. But anyways, here's the data that we found from our study that showed that poor schoolwork was by far the number one reason. And this is not just among all kids. This is among kids who came to the therapist in the school, the provider in the school for help. 43%. And number 2 is family problems, right? So this was the basis, or this recognition, even before we had the data, was the basis for the brief intervention for school clinicians, right? How do we do something that is efficient and problem solving? It gets at these things early in the chain so it doesn't go further down that sequela. All right, so what does the Smart Center do to disrupt this cycle and promote wellness? Okay, so let's look back at our little figure here. So to reduce that dysregulation, again, start with school-wide universal strategies. Just have to go there, right? It is so easy to say our first response is going to be hire people, put them in the schools. Let's please ask, how can we have a strategy that is going to provide that kind of support at a universal school-wide level? Because the research shows that you can reduce an extraordinary amount of further deepening of mental health problems if you have caring adults, if you have effective social emotional learning programs, if you teach teachers and school staff the skills to be empathic listeners and to connect with students. The data is clear. We can reduce that dysregulation that can lead to the disorders. But of course, we also, I'm sorry, a key thing that we do, last bullet, is to organize school, community, family teams to own that problem and ask what's going to work in our school building or in our community, okay? This is what the Smart Center does, is we're not, again, even though we know those programs are effective, you examine your own context, your own needs, bring people together to solve those problems together so that they own the problems and the solutions. So those teams also develop a screening system. Not just dropping a screener into schools, as Carrie knows so well. You have to have a fully functioning system, a comprehensive system to screen for kids who are experiencing the needs that we need to intervene with. And of course, we need to have then strategies to intervene early, to refer to those who might be able to provide intensive care. we strategically de-implement things that aren't working when we're talking about how we're going to meet this need. Jen will talk later about strategies in schools to prevent suicidality among youth and to provide safety planning in schools. Because again, this is where the helpers are, this is where the eyes are on the kids, this is where the screeners can be done. As Aaron was saying, the public health approach to youth mental health runs through schools. I can't say it enough. This has to be done using a systems approach, okay? So how does the Smart Center do that? Oh, well, let's talk a little bit about why, one reason why. We have to think about the systems and all of the parts working together. Because what is all too common is we just drop a new program into the schools, okay? We have to avoid the impulse to just add more people or add more programs. Initiative overload is real. All right, now I really want to hear some answers. What do you think the average number of prevention programs in schools is? In a typical school, what's the average number of prevention programs that are operating all at the same time at any given time? In a building, yeah. That'll be a lot. 20, right? 120? Well, gosh, you guys are real pessimists, which is good. The typical school operates 14 prevention activities concurrently, and not surprisingly, the research showed that they were typically not implemented with high quality, right? So instead, what we do at the Smart Center, when I say we, I mean Kelsey, Rayanne, Silva, Dr. Kleinita Graffenried, Mary Metter. I could list all of the folks who are out there on that map, all of those points of contact with schools and districts. We use an interconnected school mental health model, a systematic process to go through a sequence of steps with districts, buildings, and communities to say, what is our response going to be? How are we going to do this in a way that actually makes sense and is likely to work? So this, so as an alternative, the interconnected school mental health framework focuses on teamwork, data, and systems, not programs. So again, the first step is to make sure that you're doing an inventory of your current teams, right? Because schools will be like, oh, we already have that team. Elizabeth was saying yesterday, what was it, that the SIT team in one school
Hasn't met all year.
They haven't met. It's March, and the team hasn't even met, but it's the team, right? So what are the teams that we currently have that may be something to build on or maybe can go away? And let's try to start fresh from where they're at, right? So establish district and school community teams, inventory and strategically de-implement current initiatives. Again, a great example of where research can lead to practice, because we have colleagues who are doing research on how do you best de-implement programs. Select and implement evidence-based practices that are based on likelihood of good fit and to meet the needs across the tiers, across that pyramid. Implement that comprehensive screening system. Think about your data systems. What kind of data will tell you which kids need what kind of help? What kind of data is going to tell you whether what you're doing is working? A real classic example is discipline data. It's a real sentinel indicator of a school that is struggling. And what we have found is if you, and they have to track discipline events. State law says that you must track these things. So it's data that's available that helps you keep on track, and we can see, as you'll see a little bit later, we see incredible improvements in that sentinel indicator when we do this work well. It's just remarkable. And ongoing coaching at the systems and practice level for school and community professionals. This is what the Smart Center strives to do. And it doesn't just make common sense to do it this way, there's research behind it. So our colleague Joni Splett did a randomized trial. Remember how I was saying it's easy to study programs? She actually studied systems. They randomly assigned districts to using this systematic process versus to do PBIS, positive behavioral interventions and supports, or school mental health as usual. And they found some amazing process outcomes that people actually were more invested in the teamwork. They showed up for the teams. They did more tier 1 problem solving. But more importantly, a greater percentage of students screened using the same kind of methods in those different contexts received the help that they needed in the districts that went through that systematic process of building those interconnected school community teams. And the percent of students showing clinical levels of symptoms was reduced only in those districts that actually put together this kind of community school interconnected response. So to do this kind of work, you've got to commit to relationship building and the long game. So just to get started, what the Training and TA Center at SMART does is that they stick to this playbook of a sequence of activities. So starting with, this is an actual timeline for one of the districts we're in right now. You start with a building team orientation to the interconnected school mental health framework, assessing the current status. Tasks get done in between with the coaches helping make sure that they stay on track. Then you move to tier 1 strategies. How will we install things at the school-wide level in buildings and across the district that are likely to intervene early and reduce that likelihood of emotional dysregulation in that first step in the chain. Then they move, after some of those steps have been taken, to establishing tiers 2 and 3 and universal screening, and then continue that work. And so we have thousands of pictures. This is a lot of my work day, is sitting there doing some sort of research thing, and the training and TA team is sending in Microsoft Teams pictures from Pasco, from Nome, from Coeur d'Alene, from Battleground, all these places that they do this work in the Northwest in particular. And, it's a powerful thing. And there's Kelsey up there leading the charge. But, you can see folks fleshing out the responses that they need to see at the different tiers. And, the weight of the sticky notes that get generated, I don't know. That would be a statistic that would be interesting. That could be a moderator of effectiveness, is sticky note volume. And they're just so fun to read. I feel excited to move forward with this work. We have to quit focusing on what we can't control and focus on systems we can control. I feel hopeful, empowered that change can happen if we work together as a team with families and students, right? So it's good stuff. Okay, so let's see. So when we do this work, the programs that are selected go along with the multi-tiered systems of supports framework. And I won't dwell on this. I think a lot of you have seen these. But, again, I think we talked about this already. School-wide positive behavior supports, building relationships with all students, SEL programs, and training teachers on effective classroom management practices. That's a lot of stuff, which is why you need this kind of team thinking about how are we going to roll those things out in a way that's not going to be overwhelming, de-implement things we're doing now that aren't working or have been kind of half abandoned. Tier 2 menu of selected supports for some, right? So like we were talking about, BRISC is one of those that's being increasingly sought and trained on, but also behavioral contracting, mentoring, group, skills-based trainings for students, and then the intensive interventions for a few. Some of these would be done by school staff. We're talking about like behavior planning, might be done by a school psychologist or someone in the school social worker. But then when we're talking about more intensive and targeted treatments, cognitive behavioral therapy for different kinds of disorders, this is where you have to have that connection oftentimes to community providers. And again, screening and using data to stay on track. So just to wrap up this kind of overview, what about those programs that then we are choosing within that MTSS triangle? Our social emotional learning programs that we work through, we have an inventory that is continually updated that asks which of these programs are likely to meet the needs of your school or your district, which ones have evidence for effectiveness. We even, again, talking about the research to applied practice interface that the Smart Center tries to achieve, we now have a federally funded grant to ask how usable are social emotional learning programs for schools, right? We're subjecting them to a stress test of usability. Because from what we hear and what we see, we suspect that some are actually packaged in ways that are more likely to succeed, even if in the clinical trial they got a good effect size. Are they actually capable of being easily done in schools? So that'll be data that we bring to bear as well, not too long from now. We support implementation of strategies to boost student-teacher relationships because it's so critical, again, to engagement, to kids' emotional behavioral health, school belonging. We use programs such as, it may be something as simple as positive greetings at the door that all classroom teachers do with their kids as they walk in the room. Or it may be a more formal program like Clay Cook's Establish, Maintain, Restore classroom intervention, which is a teacher training that makes sure that no child falls through the relational cracks. There's steps that teachers go through where they literally take their entire class roster and say, which of these kids do I feel most connected to? Which ones do I feel sort of connected to? Which ones do I not really feel a natural connection to at all? Okay, those are the kids that you go have a conversation with, the ones that are at the bottom of your list. So it's cool things like that. And we do these things because they work. I mean, you train teachers to connect with their kids, and student-teacher relationships improve, academically engaged time improves, and you cut discipline in more than half because they feel connected to that teacher, right? They don't have that impulse to act out because they don't feel as though they'll be letting that person down. And moving up the tiers, last example, when the Smart Center sees a need for something to fill a gap in that pyramid, you know, we either find it or sometimes we build it. So here in Seattle, Elizabeth and her team observed that the modal number of sessions that kids were getting in the school-based health centers was either 1 or like 30, right? So kids either came and were subjected to like an hour-long intake interview and were like, I'm not doing this, or the clinicians would have an orientation to see the kid for 30 sessions or more and have caseloads of like 10 or 12 of long-term cases. And so we know that 80% of kids don't get what they need. We needed something more efficient. So based on the work going on in King County, Elizabeth and Aaron was there at the beginning, and others came up with a much more brief engagement, assessment, brief problem solving, and triage intervention, or practice really, a strategy that could be done by school staff or the clinicians coming in from outside agencies. And with the explicit idea that you got a next step after 4 sessions, you're not holding on to these kids. And the data from our clinical trial found that it actually did promote this efficiency. Fewer than half the kids, compared to services as usual, were still needing care after 4 sessions. And the referrals to more intensive mental health services was like 5 times. They were explicitly instructed, like, if at 4 sessions you find that they need something else, well then give them something else. Get them referred. But it wasn't at the expense of outcomes. In fact, the outcomes were better for the brisk group on some things. Fewer students were in the clinical range on the Columbia Impairment Scale, for example. So that is a whirlwind tour of the way in which the Smart Center does some of this work, including some of the programs that we look to install thoughtfully and in partnership with schools, communities, and families. And continuing on that theme, I want to introduce my good friend and colleague, Jen Stuber, who's going to talk about suicide prevention in schools.
We're done at 9, right?
No, 9:20.
Oh, 9:20. Okay, cool. Awesome. Great. I guess I'm very, very happy to be here today. It's actually an honor to work with this team. I'm Erin and Eric and Elizabeth, who's been an incredible mentor to me also over the years. It's honestly awe-inspiring to see all that you've done, and to see that timeline was really cool. So as many of you know, my passion is really around suicide prevention. I am actually a suicide loss survivor, and then subsequently lost my husband to suicide in 2011, and then subsequently went on to make suicide prevention my professional passion for, now it's been over a decade, and I founded Forefront at the University of Washington and really enjoyed my time there, and I actually helped develop a very robust school-based program called Forefront in the Schools, and then decided that I needed to just do something different than be in charge of a center, because it's actually very, very time consuming to do all of those pieces, and burnout is a real phenomenon. And so I joined my colleagues here, but have not left my work in suicide prevention behind. And in fact, I have really felt that I was a very intentional move to bring the suicide prevention work that I was doing to the Smart Center, because I truly believe that without this systems approach, that we're not going to get where we need to go around suicide prevention. Why is suicide prevention in the purview of schools? So, everyone says academic achievement is really the purview of schools and their most important primary goal. Of course, that's what we think, right? But actually, if we back up a second, no parent lets their kid go to school if they don't think that they're going to be safe when they get there. No one would go to school if they thought their kid was at risk. And so, that has obviously become every parent's greatest fear is like, school shooting, for example. But if you think about it, and that happens, and that's real, and it's a phenomenon that's forever increasing. But ultimately, it's about 20 kids per year, on average, we're losing through school shootings. But if you think about school suicide, look at the order of the magnitude difference. We've got 2,000 students across the nation who are dying by suicide, which means that there are 2,000 schools across the nation that are struggling with suicide losses. In our state, it's more like 250 schools. Sometimes they're clustered. The contagion risks are real. But the reality is that's a safety issue, a fundamental safety issue. And as Eric has showed and hammered home through his entire presentation, that's the tip of the iceberg. If you think about what's going on underneath that iceberg, it's the risk factors for suicide that we can see far in advance if we're doing this early detection and screening, and just raising awareness generally amongst all the people in the building and amongst families and communities. And so I really think it's critical that suicide prevention work is considered just a program. And I hate to say it, that's kind of how it's been looked at. It's a program that we implement, and schools are terrified of it. They don't know what to do with it. And the reality is we need to be thinking in a multi-tiered way about suicidality, because suicidality, you can't disentangle that from social and emotional well-being. You can't disentangle that. And so we need to be thinking at all the tiers about suicide prevention and how that fits, not as a program, but as fully integrated within a multi-tiered system of support. So that's why I came to the Smart Center, because I don't think that suicide prevention is being done that way nationally. And so I'm not going to go into these very heavy slides because I don't have a ton of time, but I do believe that we can do that. And I'm not going to claim that we're fully there yet at the Smart Center, but I do feel like we've taken some major steps forward by doing some really in-depth work with a few school districts in our state. And so what I think really can happen at the prevention level is, Eric already spoke about universal screening, what we call mean safety. Are we actually making sure the building is safe from things that could be potentially used in suicide attempts and deaths? It's an important way to be thinking about the safety environment and orienting ourselves to school safety, even in terms of suicide. I think our SEL programming 100% needs to be more thoughtful around suicidal ideation and what are the key risk factors and protective factors that we must mitigate and build within that SEL programming. So one example of that is, shame and humiliation is a huge experience for young people. and that can pertain to academic stress or other kinds of marginalization that youth experience in schools. And it's an example of a risk factor that looms very large for teens and for young people, and yet most of the SEL programming that I look at isn't doing very much on that front. And so, like, what are we actually doing around teaching students how to live with feelings like those feelings around shame and humiliation? So, like, that's an example of where I think it's a tier one strategy that we need to be getting after, developing healthy coping strategies in response to dysregulation. So DBT in schools, the MASs, I think have done an amazing job of trying to really make the case for tier one suicide prevention programming without calling it that in schools. Intervention, I'm really grateful to have had such a great interaction with Sarah Danzo and Elizabeth McCauley this year. First off, I think some of that targeted risk factor and protective factor work can happen at tier 2 and must happen at tier 2, with students being, working together in affinity groups and whatnot, being supported in that way. But I also think through universal screening, we can get to more multi-gated screening, and we must do screening for selected students around suicide risk. I would argue it should be more universal, but I think that's a really tough argument to make universally across schools. So think about, where are you putting suicide risk screening? Right now, it definitely needs to be part of the screening process. I think we all would agree with that. And I think the big piece is, like, what are you doing? How are you training staff to actually know what to do to intervene when they do that screening? And I think right now we're doing is we're just basically freaking out when we have suicidal thoughts, and we send people to the community and we say, okay, hope that works out for you. Whereas that is not the approach. With the numbers that Eric showed earlier, with the 1 in 5 students, we can't just be sending all those students to emergency rooms. We have to get real about actually how are we supporting those students in buildings, and what are we doing first and foremost to also make sure it's not just we're intervening with the individual student, but how are we getting the parents and the caregivers on board with, okay, this is a really important time for us to come together and figure out what's the next steps. We don't just shove them to the community-based provider. There's a time and a place for that. I'm not saying there isn't, but how do we, really build an intervention that everyone, school professional staff, can do? And actually, I think it's not the safety plan, thanks to your insight. It's actually really promotion of the protective factors at that level, and working really closely with families to give resources and important information. And it's also bringing the partners, the family partners, and the students and the teachers and staff very clear information about how do you help someone who is in need of support. We're all seeing it and experiencing it. The students are hearing about it first from their peers. The teachers are noticing things that are really concerning to them. And so it's not rocket science. It's like, what is the district doing to what's their process? What's their procedure around this when they have these concerns? And then feeling that the ESAs, the school professional staff, can actually do something about it and know exactly what they're doing to support students at different levels of concern. Are you thinking about suicide? Are you taking steps? Et cetera. And then a clear step for what are you doing with the community. And so I've really had the opportunity through my work at the Smart Center to kind of dig in on what that looks like in a couple of school districts, and really try to deeply understand, when is a school ready to even do more than that? So Eric put up safety planning as a tier 3 and intervention. And I do think there's a place for that work, but we definitely have to feel like the school is ready to take on that kind of capacity for doing a deeper intervention, because that involves follow-up also, and really in-depth collaboration with community providers. But I think there's so much that we can do, and this is a model that I've developed since coming to the Smart Center. It's called Asking is Caring, and it talks about look, listen, ask, act, and connect. And those steps, you have to really work it through with the school district. Like, what does that actually mean? To do that with respect to suicide prevention, because it looks a little bit different in every school district. And then these key players, as I said, it can't just be, they refer to them as ESA staff, the school nurses, the school psychologists, the school social workers, et cetera, the counselors. It can't just be their job. It's actually, everybody has a role to play, and everyone needs to be on the same page about what it is that this district is doing. And it's not an option. We have to get there at some point. We have to get there at some point because we can't just ignore the safety risks that are really happening in our districts. Yeah, and I just wanted to just say, actually, what has been the most meaningful part of this work for me since coming to the Smart Center has been the opportunity to really work and partner with families. Families are an incredibly important asset in this space, and we have to be bringing them in a universal way and in a tier 2 way. At the moment that we have a concern about a student, we really need. Sorry, I'm talking to this slide too. We really need our. Sorry, when it shows you the thing in front. We really need our families to be involved at a very early stage. You know, I think there's some universal education that can be provided to families at the tier 1 level, but then we also need support for our families because we know that students are going to fare better when they're experiencing suicidal thinking, if they're supported by families. And the families have a gut check about, you know, what really needs to change in terms of the way we're doing things, in terms of some parenting strategies, as well as some means safety issues, like what really needs to happen, and what better way to educate families and to walk alongside families than to have families doing that themselves. So I've cultivated at the Smart Center a cohort of parents with lived experience of their students' suicide deaths or attempts, and they are the educators for families in those districts, and they can do it. Like, not only can they do it, they're incredibly powerful and compelling partners to the school district, but also to the parents who are going through these struggles. So that's been like the most rewarding thing. And of course, building out the model is something that we're very much committed to and in process of doing. We have moved on and done an incredible job now working with the ESA staff and really trying to figure out what can they do at what level. And now we've formalized that into training for ESA staff. And the next few months, we'll be finishing it up with like, how do we, with a couple school districts, how do we get the teachers and the children, the peers, the students involved in this conversation so that it's not just one group's responsibility, it's a whole community approach. So let me hand it back to Eric. We didn't really practice this transition, but here.
Thanks. All right, well, I'm going to call on a couple of our colleagues in about 3 minutes to just kind of give us their perspectives. Megan Fry and Carrie McCarty are doing work in schools, with schools every day, and I really wanted to hear from them as well because they are part of this community response. Just a couple minutes on data. We assiduously track our processes and our outcomes, right? As best as we can. We're trying to drive our work at the Smart Center with data. So just a few examples. We consistently collect in those districts we're working in a measure from the district system fidelity inventory about how well their infrastructure is to actually do this work at a system level. And this is an example of a district recently. You can see overall scores, but we also look at the individual domains of support for effective school mental health and ask, where is progress being made in this district or this building? What more can we do, right? From the stakeholder engagement we keep talking about, to the funding and alignment, to the training and coaching and the data systems. We look at the impact on the workforce using a standardized measure called the impact of training and technical assistance. So for example, when we do a 1-hour web-based training, we see a little modest bump in folks' expression of their mastery of the content. But we know that when we actually do a full-day training plus follow-up and consultation, that feeling of mastery is much more established in the staff. So we use these data across literally hundreds of trainings to say, what are we getting out of what we do with in the TAC core? But really important, the most important thing is student impact. So we, for example, in the brief intervention for school clinicians, we ask those that we train to feed us back the data on the symptoms that their kids are experiencing. And what we found is that we've gotten better, in a lot of cases, over time at helping these helpers get kids better. So what is it that we're doing that might be increasing the slopes of change? The blue line is our most recent training that we did in a district in Washington. Better improvement than in our clinical trial. So we must be doing something at least equally well, if not better. And then finally, last example. I was talking about the power of the relationships between teachers and students. In Pasco School District, as part of that interconnected systems process, a team of teachers and school staff said, you know what, we're beginning to build those tier 1 things or think about what we can do. Let's just start with positive greetings at the door. And what these data show is that compared to the previous, the positive greetings at the door started in January 2024. The blue bars are the discipline incidents in the months after they started this, just a couple months ago. Look at this decline. It was going up before they started doing this, which is why they were saying, we got to do something about discipline. And Smart Center said, you know, you might try this. And they owned it, and they did it, and their teachers are doing it, and they're cutting discipline rates in more than half, right? It's just extraordinary. You feed that back into the system, and it reinforces them what they're doing and how they're problem solving around this. Here's a drawing that one of the kids did. I like when you greet me at the door because we talk about our feelings. I love that. And this is the line of kids, and she's saying, I want a high five, because they have a list of, do you want an elbow bump? Do you want a high five? Do you want a fist bump? Do you want a hug? It's up to the kids. And every one of them gets whatever they choose. I want a high five. And look at these quotes from the kids. I like when you greet me at the door because we talk about our feelings. I like it when you greet us at the door. It helps my day because I get to share my feelings. I like you giving me hugs. If you rush and you don't greet us, I would cry. So I'm going to now ask if we have a microphone. I would really love to hear Megan Fry, perhaps first, because you're closest. Megan, maybe describe a little bit of the work you're doing and the things that you have seen about school community connections and maybe barriers or any kind of positive kinds of strategies that you have seen. I would just love to have you contribute.
Yeah, sure. My name's Dr. Megan Fry. I'm a psychologist at Seattle Children's. My main clinical work is at the Odessa Brown Children's Clinic, and so I am a school psychologist by training and also a school behavioral health provider. My current role really focuses on consulting with providers in schools who are implementing these practices. And I think the biggest thing that we're struggling with right now is how us in schools are understanding the resources available in community and how we're using and getting kids access to those resources, particularly for kids who really won't be able to walk through an outpatient clinic door. And so we're struggling, I think, with this intersection of how many kids we want to see in schools because they won't be seen anywhere else, right? For accessibility issues, for equity issues, they won't walk through outpatient clinic doors or Seattle Children's Hospital doors. And the charge of schools to be preventative efforts because that is where subclinical presentations of needs exist. So it's this like inverted pyramid that in theory the outpatient clinical setting would manage, right? We could say this kid needs an intensive outpatient program or a partial hospitalization program, and that student would go get that at the hospital. But sometimes that student can't make it to the hospital, or that student doesn't speak the language that that program is offered in at the outpatient clinic. So having that balance of trying to help my team provide quote unquote tier 3 intensive services, but also move kids through quick enough that more kids can be seen is a big barrier. And also just building confidence in people in the school building that are not licensed behavioral health therapists to say, gosh, your positive greeting at the door, like that actually makes a big difference. Because what we often see is a teacher feeling like, oh, a traumatic incident happened for this child and they need therapy, right? Like, I don't know what else I can do but get them therapy, and look, there's a therapist here, so that's who I'm gonna send them to. So I think it's helping systems understand that, and also, you know, the uniqueness of our work is that we work with licensed folks who work within schools. And so sometimes that means multiple entities who are private and district and county, all communicating and speaking the same language. And right now, sometimes it can feel like this amazing influx of financial resource, which is great.
Yeah.
I'm very, very pleased with that. But it's like we're all rowing against the same current in a different lifeboat, is really how it feels.
Yeah.
So I think through our consultation work, we're trying to connect folks together. I think what you've talked about today in the interconnected systems is wonderful, and I hope that more districts will think not just about what we're doing within the school district staff, but how we're using and connecting with community resources all at the same table. So that everyone knows what's happening, not just in the building, but what's happening, you know, around, outside of the school doors too. So, thanks.
Thank you so much. And Dr. Carrie McCarty, I also really would love to hear from you about what your perspectives are.
Thanks. I'm going to get a kink in my neck here. Really appreciated this grand rounds, and I've taken a lot of notes, connecting it to my own work. I'm going to speak a little bit about my role as program evaluation lead for the Best Starts for Kids SBIRT program, which I've been doing for the last 5 years. And SBIRT is a screening, brief intervention, and referral to ... anything the kid needs, not just treatment. So that's my first point, is not every student needs therapy. And I think we've been very mindful of that in the Best Starts for Kids program. Some of the other things that we often refer kids to, now some of them do, are study skills and tutoring resources, right up there with the academic stress. Job opportunities for high schoolers, pro-social activities. Some of them need primary care. We figure out after they meet with somebody, they actually don't have medical services. And then the school also uses the data that they get at the school level to inform what kind of tier 2 supports they need to build within the school. So they can look and see, you know, we have a number of students who are grieving the loss of somebody. We're going to add a grief group this year. Or we have LGBTQ students who are feeling unsupported, and we really need a special place and more activities for them. So that's another way I think using data at the school level is so helpful, and using it to improve the services and to create a system within the school. And then for those kids who do have the higher level needs, I do think it's important to think about for them creating a support person within the school as well as building a support outside of the school. So some of those kids who are going to need that longer term care are just going to need to have a little bit of both, and we really want them to have redundancy there. Somebody at school they can go to during the school day, and somebody who's offering the deeper level of family support that schools aren't often able to provide. And I'll give you an example, a story from something a student we learned about last year. So we expanded to screening high schoolers 2 years ago, and one of the areas we did focus groups with high schoolers to determine what areas to add. We added screening for eating problems, because since the pandemic, there's been a huge rise in eating disorders as well as subclinical eating issues. So we screened, and there was a student who emerged, and it turned out she actually was in therapy. She had a therapist. She had an identified eating disorder, and the school knew nothing about it. It was completely off everybody's radar. So this student was going through the entire school day without eating because the cafeteria was overwhelming. You know, all of the issues about eating in public and all the people there. So it was really a simple intervention for a student who had an existing resource, but how could we bring that into the school and create supports for her around the school, which just hadn't happened until that screening process occurred. So I do think that collaboration is really critical, Eric.
Yeah. Thank you guys both so much. I mean, you hit on a lot of the points, right? data is available, programs and staff are available. How do we make sure that it's being done in a kind of interconnected, systemic way?
So could I add?
Absolutely.
I'll just shout it out. Oh, I don't. I just want to add very much to what both Megan and Carrie said, and I think the most important thing that we're learning currently is that some of this new money and these initiatives are focusing very strictly on mental health therapy, and what we're seeing from our data, talking with kids and people in the school, is we need this continuum of care, and not, as Carrie said, not everybody needs therapy, and we really need to be working in a more coordinated way with our mental health support, working with the other resources in the school building. And I love your example of the eating disorder kind of situation where somebody needs to help that kid be able to eat in the school, but that they don't need to take on the whole 9 yards. Just really important for us. I feel like as we use all the data, I've used it myself, we use it all to say, all this rising anxiety, depression, suicidality, but the reality is we have to, as Jen pointed out, start lower and do this early intervention and prevention. Anyway, I could talk all day about it because we are not doing that well in the community, the school setting.
But we can, and we've seen that it's possible, and it really is. And so I think we're out of time.
Yeah, we are out of time, and I just want to say thank you, and that this is a model of how to, and kind of a great example of just a fantastic resource in our own community that I think we can continue to work on. How does the clinical piece intersect with the school piece, and really appreciate the discussion and the 10 years of work that you all have been doing. So thank you very much.
Thanks, Carol.